Guys, there seems to
that seems okay. The volume is not there, I guess. Thank you. That was nice. Dr. Simmerpreet?
اول من بعد سیما پریت بعد ویدیوشونه بعد ران کنید خواهی بنویسید دکتر الان نگفت الان همین الان دکتر باشه
من استفاده کنم چون یه ذره بهتر از موضوع چی شد؟ شما هستین؟
همه هستن شما نیست دکتر داره کار دیگه میکنه دارم مهندس کنم So good morning, everyone. Shall we start?
Yes, we are on time. Thank you very much.
Okay. Good morning, everyone. Now, we are facing a global health crisis caused by COVID-19 pandemic. Almost all the attention of the worldwide press and healthcare services is focused on this disease. Nevertheless, other diseases with significant clinical impact, like oral cancers, continue to occur. I am Dr. Nazanin Mahdavi, head of the Department of Oral and Maxillofacial Pathology in Tehran University of Medical Sciences, briefly TUMS. TUMS School of Dentistry is the oldest and foremost dental center in my country, Iran. And our department, as the first department of oral and maxillofacial pathology in Iran, which was founded almost 55 years ago, used to receive many cases of oral benign and malignant cases. Of course, before the COVID-19 time. During the lockdown, we had much less biopsies. And after the lockdown ends in my country, although we still have less cases than before the COVID-19 time, an increase in the number of malignant oral cavity lesions, usually with higher stages, attracted our attention. It seems that there's a greater chance for pre-malignant or early malignant lesions to be missed in the present time so they can develop into higher stages cancers. Malignant and pre-malignant lesions. These are the topics that our two eminent lecturers are going to discuss. I'm proud to say this webinar is held in collaboration with Asian Society of Oral and Maxillofacial Pathology. Now, with honor and respect, I would like to invite the Secretary for Asian Society of Oral and Maxillofacial Pathology, Dr. Simaprit Sandhu. Please welcome, Doctor.
Hi, everybody. Good morning. And we are on the third episode of the SOMP webinars. I would like to thank Dr. Mahadavi and acknowledge the presence of Dr. Puan and our honorary president, Dr. K. Ranganathan, and Counselor for India, Dr. Mandana, and all the AOMP counselors and advisors, everybody. So now I'll briefly introduce ASOMP, which is known as Asian Society of Oral and Maxillofacial Pathology. It's a non-profit organization of individuals organized exclusively for international networking, scientific, literary, and education purposes. A SOMP was established in 2003 as an academic society designed for dissemination of knowledge concerning oral pathosis. There was strive to contribute to the expansion of academics in Asia through communication, cooperation in education, research, and practice. It aims to promote the study of oral pathology and medicine, develop the treatment of oral diseases and disorders, and advance knowledge in clinical aspects, laboratory diagnosis, and research. The ASOMP is a strong council which is headed by our honorary president, Prof. K. Ranganathan. As already Dr. Mahadavi has told you, I'm the Secretary General. Our past president, Prof. Roshna Zain, and advisors, Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. Prof. Takashi Takata from Japan and Prof. W.M. Tilakratne. Now, may I request the IT team to kindly play the SOMP video to take you, it's just about 2 minutes to praise you of a SOMP. IT team, please play the SOMP video. I think, thank you so much. There was some overlapping of voice. And now I am extremely delighted to introduce the first speaker of today, Dr. Ranganathan, who's going to be deliberating today on the topic of oral premalignant lesions. Dr. K. Ranganathan is presently heading the Department of Oral and Maxillofacial Pathology, Raga's Institute of Dental Sciences, Chennai. He is the, just a moment. Currently heads the Department of Oral and Maxillofacial Pathology. He is the Honorary President of Asian Society of Oromaxillofacial Pathology, Secretary-elect International Association of Oral Pathologists, past President of Indian Association of Oral and Maxillofacial Pathology, and is currently the Chair of Fellowship Committee of the Indian Association of Oromaxillofacial Pathologists. He graduated his Master's in Oral Pathology from Tamil Nadu Dr. MGR Medical University, Chennai, India in 1990 and did his PhD from the same university in 2010. He also has his master's degree in oral pathology from the Ohio State University. He successfully completed the fellowship exam of American Academy of Oral and Maxillofacial Pathology in 1996 and was conferred the Fellowship of Indian Association of Oral and Maxillofacial Pathology in 2010. He was awarded the Best Teachers Award in 2011 by the Tamil Nadu Dr. MGR Medical University, Chennai. He has held the posts of Secretary, IAOMP for 2 consecutive terms, Asian Counselor of International Association of Oral Pathologists, and Secretary of Asian Society, Assam. His field of interests include oral submucous fibrosis, HIV, oral potentially malignant diseases, and stem cell biology. The Prof has more than 151 publications and has contributed to 4 texts and has been invited to national and international lectures in the international conferences. So may we present Dr. K. Ranganathan, the Honorary President of Asian Society of Oral and Maxillofacial Pathology, to deliver the lecture on oral potentially malignant disorders. Over to Dr. Ranganathan.
Thank you very much, Dr. Simmerpreet. Am I audible?
Yes, sir, you are. Very
awesome.
Loud and clear.
Yeah. Thank you very much. First, let me thank the head of the Oral Pathology Department of the Tehran Medical University, Dr. Nazim Mahdavi, and Dr. Poyan Amini Shakib. Hope I got that name right, Poyan. And for making these arrangements and hosting this webinar in these difficult times, along with the Asian Society of Oral and Maxillofacial Pathology. Let me thank Dr. Mandana Donahue and the Secretary, Dr. Simmerpreet. What you see today is hard work between these 2 members. Dr. Mandana is the counselor, Asian counselor in the Assam, and Dr. Simmerpreet working with their counterparts in the Tehran Medical University. Thank you very much for all the hard work. Thank you very much. I thank all the senior colleagues in the Assam, the council members, and the members of the Assam for being here this Sunday with us at this webinar, and all my colleagues from across the country and the world who have allotted their time to be with us here today for this seminar on a very, very important topic. So without much ado, let me go on to my presentation. I'm just going to share my screen. Is that visible?
Yes, sir, it is.
Yeah, Dr. Simmerpreet, if there is a lag, because I realize, there's a difference in the thing.
There is a lag on paste.
Just I would pace myself a little bit slowly. If you could just type in the chat box so that I'm audible to everybody and it makes there's some clarity to it. Is this okay? Is the speed okay?
Yeah, this is okay. This
is
fine.
Okay, let me just stop the video here when I give my introductory slides. I thank the staff of the Tehran University of Medical Science and all the members of the Asian Society of Oral and Maxillofacial Pathology and all the practitioners, clinicians, and pathologists from India and other Asian countries and throughout the world who are here with us today. A little bit about where I come from. I come from Raga's Dental College and Hospital. And that's the building where I work in, the top floor right there. And I invite all of you, if you're in this part of the world, I probably think it's going to take some time before we can all travel, but eventually in the future, do make it a point to visit us if you're in this part of the world. Hopefully we'll be out of this pandemic pretty soon. We are located very close to the coastline on the southern tip in the place called Chennai. And we have a lovely drive going along the East Coast, and I'm sure you'll have good times when you make it here. We are a private institution affiliated to the Tamil Nadu Dr. MGR Medical University, which is the medical university of our state, Tamil Nadu. And Raga's Dental College is a private institution affiliated to the Tamil Nadu Dr. MGR Medical University. It is a privately owned institution run by the Jaya Group of Institutions, headed by Professor Kanakaraj and his family. They run a plethora of institutions, and it is said that if you're so inclined, a child could join with the high school which they have and graduate from any of the specialties, humanities, engineering, dental, or nursing, and get an employment within the Jaya Group of Institutions. They have a significant contribution to education to this part of the world. And in addition to the education, they are involved in social and philanthropic work to a great extent. Raga's Dental College and Hospital is an institution which is about 30 years old, and we have all these specializations. And we are now currently administered by a very dynamic dean, Dr. Aragarasan. Truth be told, a lot of response which you have seen from our Indian counterparts from this part of the world is because of the enthusiasm and dynamism of Dr. Aragarasan. Both the management and the dean are very, very encouraging. And we have a very, very proactive, very vibrant student and staff community. Okay. With this brief introduction of our institution, let me proceed on to the presentation today. Hopefully by the end of this presentation, you will be able to answer these questions. What exactly are oral potentially malignant disorders? Seems a mouthful. I'll come to that in a few minutes. Why are they clinically important? What are the features histologically? And how do you really predict which of them are going to be transformed to malignancy, which is a major concern in this part of the world? And from what I heard Dr. Madhavi say, in Iran too. The first 2 points and the last question would be of tremendous interest to both the clinicians and the pathologists who interact on a daily basis to manage patients. The third question, what are the features histologically, is aimed at pathologists. So if the clinicians or the practitioners need a small break, you can take off and come and join us towards the last question. Quickly, what exactly do we mean when we say oral potentially malignant disorder, or what is called as, OPMD? OPMD constitutes 4 important lesions: leukoplakia, erythroplakia, certain types of lichen planus, particularly erosive lichen planus, and oral submucous fibrosis. You have a lot of other lesions too, like dyskeratosis congenita, actinic keratosis, discoid lupus erythematosus, which also come under the umbrella of oral potentially malignant disorders, or OPMD. But these are the 4 most common ones. And oral submucous fibrosis particularly is common to our part of the world, where areca nut chewing is a major problem. Leukoplakia, as most of you by now know, are white patches on the surface of the oral mucosa, which are not scrapable. Erythroplakia are these red lesions. They can look like inflammation or erythematous lesions, and are often misdiagnosed as inflammatory in the oral mucosa. Submucous fibrosis is due to the habit of areca nut chewing, leads to severe restriction in the opening of the mouth, significant morbidity and mortality associated with this oral potentially malignant disorder. And lichen planus. All lichen planuses are not necessarily potentially malignant, there are certain subtypes, particularly if it has erosions or red areas within the white striae, these are prone to malignant conversion. So what is this? Is this precancer? Is oral potentially malignant disorder precancer? Yes, it is what's called precancer. It has also been called a pre-malignant lesion. In some parts of the world, they call it an epithelial precursor lesion. The current accepted terminology is potentially malignant disorder. And then you have a mouthful, which is also used by some investigators and some workers. This is called potentially pre-malignant oral epithelial lesion. Now, the reason why precancer and pre-malignant fell out of favor is the fact that when you say the term precancer, you're implying that all of these are eventually going to become cancer. But as you will see in the following slides, this is not necessarily true. Only some of these lesions progress to cancer. And the clinical and the pathological dilemma is to find out which is becoming or which is going to become cancer and handle them aggressively, or those which are not going to handle them conservatively. But that is the most important clinical problem we face. So why is it important? It's important because if you diagnose it at this stage, either leukoplakia, erythroplakia, or submucous fibrosis, you prevent it from going to this stage where it becomes a problem to treat. And what is that to oral surgeons, dental practitioners, and pathologists? The interesting thing is most of the OPMDs precede oral cancer, at least when there is a risk or a habit-associated problem. Also, it's very important to keep in mind that what looks clinically like OPMD, either leukoplakia, lichen planus, submucous fibrosis, or erythroplakia, may already be cancer histologically. So you need to biopsy all these lesions. And this is very important for you to consider as a clinician. And adopting a wait and watch approach may be a problem in some cases. And most importantly, asymptomatic cancers are more likely to be detected in a dental setting. And oropharyngeal cancers are very important as far as screening protocols are concerned, because even a delay of 1 month, as little as 30 days, there is a risk of cancer being diagnosed at a late stage, which means what could have been diagnosed at stage 1, if you delay by about a month, could be in stage 3 or stage 4, which means what was completely treatable in stage 1 progresses to a stage where the prognosis is very, very bad, particularly in stage 4. So early diagnosis is a critical factor and cannot be overemphasized as far as oral cancers are concerned, which makes OPMDs all the more significant because if you can tackle them at one stage before cancer, it's a very big advantage to the patient and you can literally cure the patient. And also, if you delay the diagnosis, there is a chance, there is a higher risk of recurrence and increased morbidity and mortality. So diagnosing cancer very early is very good, but even better, diagnosing at the stage of oral potentially malignant disorders, what was called precancer earlier, is very, very important because you don't allow it to go even to stage 1 cancer. And that is why we are addressing this very, very important topic today. A little bit about cancer. This is just a quick overview to make you understand the complexity associated with major health problem. It's very important to remember that when we speak of cancer of the head and neck, it's a very heterogeneous group. Normally, when we say oral cancer, we refer to the oral cancer we see in the dental setting or the dental clinics, which is associated with tobacco chewing, tobacco smoking, or areca nut, at least in this part of the world. Oropharyngeal cancer, which is usually associated with HPV or human papillomavirus. Cancer of the lip, most of which are associated with exposure to the sun, what preceded by actinic keratosis, which is a type of potentially malignant disorder. And all these 3 cancers are different by etiology, are different by their molecular profile, are different by how they progress, how you manage, and how you treat them. So you need to understand that when we say head and neck cancer, it could be either one of these three: oral cancer, oropharyngeal cancer, and cancer of the lung. Quickly, a few statistics to underline the fact why it's so important. Oropharyngeal cancer is the 11th most common cancer globally. And in developing countries, 2 out of every 3 cancer are oropharyngeal cancers. And in high incidence areas where there's a lot of habit of tobacco and areca nut and alcohol along with these, it is one of the top 3 cancers in that particular region in the world. So it is a major problem in very many countries. So why is oral cancer such a big problem? I mean, the oral cavity is easily accessible. Why? Why is it such a big problem? It's very simple. In spite of all the advances in treatment, even today, in most of the parts of the world, the 5-year survival if you have oral or oropharyngeal cancer is only 50%. And why is this? Most of it is because of late diagnosis. Once again, underlying the fact that you need to diagnose the potentially malignant disorders and catch the lesion at this stage to have a better prognosis and a better treatment for the patients. And the other problem is there is an increased risk of multiple tumors when you have oral cancer. This could be as high as 17 to 30% with an annual risk of 3 to 10%. To put it in perspective, if a patient has oral cancer and he or she is cured of the cancer, they still carry a 20 times higher risk of developing a second tumor. And this high risk can extend for as much as 5 to 10 years after the first cancer has been cured. So they are at a very high risk. So these patients with head and neck oral cancer need to be followed up for a long time, at least for 5 to 10 years, because of this inherent risk of multiple tumors. And multiple tumors can be of different aspects, and especially if you're a pathologist or an oncologist or an oral surgeon handling these tumors, you need to realize that the multiple tumors could be either one of these. It could be a local recurrence because the primary tumor has been improperly removed. It could be what we call as a second field tumor, or it could be a second primary tumor. Let me quickly explain what this means and why is it important to distinguish between these 3. This is a little bit of a busy slide, and you have the references at the bottom. LR stands for local recurrence. SFT stands for secondary field tumor. SPT stands for secondary primary tumor. Local recurrence usually occurs less than 2 centimeters from the original lesion and within the first 3 years of the diagnosis of the primary lesion. Second primary occurs greater than 2 centimeters from the first primary lesion or a period of greater than 3 years from the primary lesion. Now, this is the clinical classification of local recurrence and second primary tumor. Either of these can be secondary field tumors. The reason is the genetic pattern of the local recurrence, the secondary field tumor, and the secondary primary tumor are different. And in this era of what's called individualized medicine, they all have genetic profiles which are different. So the treatment also becomes different. The prognosis also becomes different. So it is not sufficient if you just say that the patient has already had an oral cancer, the tumor has come back. You need to define whether it's a local recurrence, a second field tumor, or a second primary tumor, so that your treatment also has to be modulated accordingly depending upon the molecular profile, and the prognosis also alters similarly. So the biggest problem with oral cancer, once again, is it's usually diagnosed late, making survival only 50% in most of these patients. And there is a problem of multiple tumors, which could be either a local recurrence, a second field tumor, or a second primary tumor. So what is this connection between the potentially malignant disorder we're talking about and cancer? So the most common oral potentially malignant disorder which you're likely to face in the clinical context is leukoplakia. So let me show you a few pictures of how they look like. Broadly speaking, you could have what's called a thin leukoplakia, a thick leukoplakia, a verrucous leukoplakia and speckled leukoplakia, then these can all look different. What you're looking at here is a, let me see if I can get a pointer. Yeah. This, you're looking at the lateral and ventral surface of the tongue. This is a thin leukoplakia. It can be very subtle, and unless you look for it, you can miss it. This is the lower lip. You're characteristically looking at a very, very thick leukoplakia. And this is a verrucous leukoplakia. If you look carefully, you can look at the verrucous surface. And speckled leukoplakia, which is a combination of white and red areas, giving it a very, very speckled appearance. So these are all different clinical presentations of leukoplakia. And then you have a more recently described entity called proliferative verrucous leukoplakia. This is from one of our referred patients recently. You have these leukoplakias everywhere in the mouth, these thick plaques. You have them in keratinized mucosa, you have them in non-keratinized mucosa. Many times they are not associated with habit, and they have a verrucous surface, and that's why it's called verrucous leukoplakia, and you excise them and they keep coming back. And these are a major problem as far as treatment is concerned. And then you have a more newly debated entity called the Varicose Hyperplasia. And many clinicians look at this and immediately say that it is an oral cancer. But multiple sections of this particular lesion did not show any invasion into the underlying connective tissue. We just had pushing basement membrane. So technically speaking, it's still not cancer. And it didn't have features of verrucous carcinoma too. And so this is an entity called verrucous hyperplasia. And a lot of us are trying to get our head around this lesion and define a set of characteristics by which we can identify them clinically and histologically. So we can tell the clinician what exactly to do and tell the patient how it has to be managed. Okay, so these are the different types quickly, summarizing on them. Thin, thick and homogeneous leukoplakia, the nodular or the verrucous or granular leukoplakia, the speckled leukoplakia, the proliferative verrucous leukoplakia, and of course, the hyperplasia, verrucous hyperplasia, which I told you. But you need to understand that leukoplakias are clinical diagnosis, and these are not histological diagnosis, and no histological report should have a diagnosis of leukoplakia in it. So what exactly is it pathologically? If you talk about clinical and pathological, you're looking at a patient's mouth as leukoplakia. It is a potentially malignant disorder. So it carries a risk of malignant transformation. And so you need to investigate this. So what can it be? What can a leukoplakia in a patient's mouth be? When you submit the tissue specimen, you may get a report back calling them as no dysplasia, mild dysplasia, moderate dysplasia, and severe dysplasia. We'll talk about these in a few minutes, in a few slides from now. You need to keep in mind that what is leukoplakia can also be carcinoma in situ. This terminology has been dropped in the recent classification, and we'll talk about that too. Most importantly, what you see clinically as leukoplakia could already be a carcinoma, as I said a few slides back. So it is important to remember that what you see clinically as a leukoplakia, erythroplakia, the different types of leukoplakia, erosive lichen planus or submucous fibrosis, could either be dysplasia or could already be a malignancy or a squamous cell carcinoma, making it very imperative that you biopsy these tissues quickly and make sure that your diagnosis is, whether it's a dysplasia, whether it's a carcinoma in situ or carcinoma, so you can take steps accordingly. Now the question is this, which OPMDs will become cancer? How do you do it? How do you know which of them is going to become cancer? What do you do to diagnose them? The gold standard for diagnosis is biopsy. And there is, we could talk a whole session about this. There are different ways in which you can sample tissue. You can do a scraping of the superficial surface, which is called exfoliative cytology. You can use specialized brushes called cytobrushes. You could use an aspiration, you could use a punch, and you can use an incision. By and large, currently the gold standard is a biopsy. If it's a large lesion, you do an incisional biopsy. If it's a small lesion, you do an excisional biopsy of the potentially malignant disorder, and there is no two ways about it. And once you do that, you get back a report whether it's dysplasia, carcinoma in situ, or cancer, and you can proceed accordingly. Which comes to dysplasia. I said there are different types of dysplasia. What are these? And how exactly do we grade them? Oh, this is a very, very busy slide. And this is just to tell you that how different people working on dysplasia from different parts of the world use different systems and how they coordinate that with the treatment protocol. You have the WHO classification, and we currently use the WHO 2017 classification, of which I'll talk about a little bit in detail. There is the squamous intraepithelial neoplasia type of classification. Our ENT colleagues use what's called the Ljubljana classification. It's elegant in some ways. Then you have the squamous intraepithelial lesion. Then you have the Japanese Society use what is called the YN or carcinoma in situ classification. And what is now becoming a very popular is a so-called binary system with its different variations. I shall talk a little bit in detail about the WHO 2017 classification of the dysplasia, which is widely used in clinical practice, and we use that too. And why a lot of us feel that we need to shift to the binary system to enable an effective interaction in the clinical context and manage the patient appropriately. The WHO 2017 classification is based on three things: the architecture of the surface epithelium, the cellular changes within the epithelium, so-called cellular atypia, and the thickness of involvement of the surface epithelium, to what extent, to what thickness the surface epithelium exhibits the cellular atypia or the architectural changes. This is the 2005 classification, actually showing the architectural changes and cellular changes, and we have the entire list, and this is available. I'm not going to go through each of them individually, but what is important to know is from the 2005 classification, the basal cell hyperplasia and the increase in nucleus size has been removed in the 2017 classification. And so you have the 2017 classification with those two entities removed, which is basal cell hyperplasia and alterations of nucleus size. And you have one architectural change incorporated, which is called the loss of epithelial cohesion. So that has been incorporated into the architectural changes, excuse me. And these are the current features we use to diagnose dysplasia. The architectural changes include changes in stratification, a loss of polarity, the shape of the rete ridges, the presence or absence of normal and abnormal mitosis, the premature keratinization and keratin pearl formation, along with the loss of cohesiveness of the epithelial cell. And the cellular changes include alterations in different ratios and individual changes. I said the WHO 2017 classification uses architectural changes, cellular atypia, and the thickness of the epithelium. So if these changes, the architectural and cellular changes are restricted to the lower 1/3, we call it mild dysplasia. It involves the 2/3, we call it moderate. And then if it involves the upper layers too, we call it severe dysplasia. So this is the extent to which the cellular and architectural changes involve the surface epithelium. So how has the classification evolved? So what are the changes? How did we arrive at 2017? If you look at the 1978 classification, we had mild, moderate, and severe. In 2005, you had what is called squamous hyperplasia, which is called no dysplasia in 2017. And this is very important. We had two classifications, severe dysplasia and carcinoma in situ in 2005. And that has been eliminated to call it as, so we call it now severe dysplasia. So we have no dysplasia, mild, moderate, and severe dysplasia. And you're likely to get one of these when you submit a leukoplakia for a biopsy report. So this is fine. I mean, you have dysplastic changes, and it makes sense to tell that if the epithelium has got severe dysplasia, they have a higher risk of transforming into malignancy. If it is milder, the lower risk. So where exactly is the problem? The problem is there are a lot of difficulties in diagnosing a dysplasia by the pathologist. And what exactly is the difficulty? Let me show you two examples which highlight this problem. In this particular case, you have severe architectural change restricted to the lower 1/3. And the cellular typia is moderate. So the cellular changes are moderate. However, the architectural changes are severe and it is restricted to lower 1/3. So by definition, it should be mild dysplasia. But when you combine all the three features, including the cellular atypia, the pathologist may be inclined to call it a moderate dysplasia. Though technically, if it's according to the classification, if it's restricted to the lower 1/3, you need to call it as mild. So this can be an issue, one issue in diagnosing dysplasia. Now, if you take this example, the architectural change is up to the middle 1/3, and there is severe cellular atypia. Because it's up to the middle 1/3, you need to call it moderate. But because of the severity of the cellular atypical changes and the reduction in the thickness of the epithelium, it will be called severe dysplasia. So now you see where the problem is in rendering a report of dysplasia. Though the definition is very clear, you use architectural changes, you use cellular atypia, and the thickness to which these changes occur. In practical situations, there may be a mixture of these severities in the architecture, cellular changes, and the level of involvement, which may downgrade or upgrade the dysplasia. And you may have to treat it accordingly. So because of this inherent problem with the so-called three-tier system, where you have three tiers, mild, moderate, and severe, there has been an interest in trying to use what is called a binary system, where we only have two groups of classification. So what exactly is this? You look at the WHO classification on the left. You have mild, you have moderate, and you have severe. Of course, we don't have carcinoma in situ now in the recent classification. And you shift to the binary classification here. The mild becomes what we call low-grade dysplasia. The severe is high-grade. But this is where it becomes a little bit different. Some of the moderate become low-grade, and some of the moderate become high-grade. So basically, there is a bifurcation of the moderate dysplasia depending on certain features. So instead of having mild, moderate, and severe, we have low-grade dysplasia and a high-grade dysplasia. Some of the moderate dysplasias are shifted to low-grade, and some of the moderate dysplasias are shifted to high-grade based on a few histological features and clinical features we'll talk about towards the end of this presentation. So this is what is the binary system and its translation from the WHO dysplasia grade. So mild, low grade, severe, high grade. Some moderate dysplasias become low grade, some moderate become high grade. So what is the cutoff point? When do you call some of the moderate dysplasia low grade, some high grade? Once again, there are two schools of thought. One group which has been reported by Kuyan et al. They consider 4 architectural and 5 cytological changes as the tipping point between low grade and high grade. And Nankivel and their group have fixed on 4 architectural and 4 cytological changes to improve the prognostication. So you have a set of points with respect to architecture and cellular changes, which you could use to dichotomize your moderate dysplasia into low grade or high grade. Those of you who are interested, this is a recent publication from our group, and we did a comparison between the WHO 3-tier system and the binary system. And there is an extensive discussion on what the problems are and where exactly the problems arise and what we can do to improve our reporting of dysplasia. So the problem, once again, is like I showed you a couple of examples, histological examples. Dysplasia grading can be subjective, and there can be variation both between 2 observers and within the same observer at different points in time. And we normally do what is called the kappa for consistency. where 1 means both the observers totally agree or both the observations are totally in agreement, and 0 means no agreement. And usually, if you look at different studies, the kappa ranges from between 0.15 to 0.69. A kappa of about 0.6 is good, it's pretty good. But you can see that where it becomes tricky to reproduce the grading of dysplasia in some scenarios. So why? What is the reason for this variability? Why is there a problem? One, of course, it's the subjectivity, which to some extent is based on the experience, which is how many slides are looked over a period of time. If the specimen has a lot of inflammation, then it becomes a little bit difficult to diagnose. Certain sites, particularly the gingiva, are prone to a lot of secondary changes, and they can be difficult to diagnose correctly as to the grade of dysplasia. And an optimum biopsy is absolutely necessary. And that is why I stressed the fact that you need an incisional or an excisional biopsy, because grading of dysplasia can be a little bit difficult. And if you have a suboptimal specimen, the difficulty increases many-fold. So it is good to have an incisional or a good excisional biopsy from the representative side to give a useful diagnosis to the clinician. Okay, sorry about that. What is the solution to this subjectivity? What is the, excuse me. What is the solution to this subjectivity among pathologists? Do we have an answer to this? But this is an old slide of mine from one of my colleagues, but I still like to use it. You see the clinical progression from normal to potentially malignant disorders to cancer. And then you see it takes about 10 to 15 years for the histology to progress to cancer. Interestingly, the molecular pathology or the molecular lesion associated with the tissue also progresses as you progress from normal to potentially malignant to cancer. So we could use these molecular changes along with the clinical and histopathological features to accurately detect which of them are going to become cancer and which probably will not. And you have tons of markers for this. I mean, you have markers which measure numerous things, right from DNA damage to ploidy status to loss, LOH, inflammation, cell cycle and proliferation, and you have the reference right up there and you can take a look at it. And these things change as the tissue progresses from normal to hyperplasia to potentially malignant, clinically or dysplasia histologically, and frank oral cancer. To make it, to sort of simplify this, this is a little bit of a simplification, but it has been said that from normal to cancer, you need approximately about 5 oncogenic events to take place. And there are numerous oncogenic events which vary from cancer to cancer, and the different types of head and neck cancer. But some of the common ones are P53 mutation and stabilization, which occurs very early on, and then changes in chromosome 3, 9, and 17p segment. And later changes include those in 8, 11, 13, and 18. And then you have numerous others, and this is a huge list which keeps increasing every day. And there are numerous techniques we have access to, which can actually help you in analyzing the different types of potentially malignant disorder and the risk they carry as far as malignant transformation is concerned. You have systems like microsatellite-based genetic analysis, loss of heterozygosity studies, DNA ploidy analysis, immunohistochemical analysis, fluorescence studies, microarrays, and it's a huge list which keeps going. We have newer techniques like nanostring and other newer techniques. But 2 techniques which have shown good promise and which can probably use routinely in the clinical context are loss of heterozygosity and DNA ploidy. We'll talk about this for a few minutes. This is one paper by Kip and his colleagues. This is an interesting paper where they have used loss of heterozygosity. They used what is called fluorescent capillary electrophoresis. And they used a few specific markers. One marker on 9p, another marker on 3p, another marker on 17p. So they did a LOH study of this. If there is a retention, they did a 3p marker study. And if again there is a retention, they classified it as low risk. And MR stands for molecular risk. If there was a loss of heterozygosity in chromosome 9, they went ahead and did a 17p marker. If there was a retention, they called it intermediate risk. And if there was an LOH or a loss of heterozygosity, they call it a high risk. So you could use LOH along with your clinical features, along with your histopathological feature of dysplasia. You could do a LOH study, which is feasible if you have it available at your center, and further stratify the dysplasia as low risk, intermediate risk, and high risk, depending upon the LOH profile of the potentially malignant disorder. Another interesting tool which has caused a lot of excitement, was used a few years back, fell out of use because of certain controversial reasons, and is again making a comeback, is the use of ploidy analysis. And this is very exciting, and this could prove a very, very useful tool in the near future in our prognostication of potentially malignant disorders. Now this figure, and this is the article, you have the quote on the left by Van Zyl and his group. This is a case of moderate epithelial dysplasia. The DNA content was diploid, which means the risk is relatively less for malignant transformation. This is a mild dysplasia with aneuploidy, which means it carries a higher risk of malignant transformation. So you have moderate with diploid status, and you have a mild with an aneuploid status. So the mild with an aneuploid status has got a higher risk of malignant transformation. So now you see how you could club your dysplastic features along with the molecular lesion. You may not be able to use it alone as a standby measure. You could club it with your clinical, the histological rating, be it the 3-tier or the 2-tier system, and then use techniques like LOH and ploidy analysis to come to a judgment as to how you need to approach that particular lesion. And once again, here you have a moderate dysplasia with aneuploidy. So if you have two cases, one patient with a moderate dysplasia with a diploid status, another patient with a moderate dysplasia and aneuploid status, you need to treat the second one more aggressively with a more aggressive follow-up and a management protocol. It's important to not lose sight of the fact that we keep talking about genetics, but there are things called epigenetic changes, and there is a lot of excitement growing as far as epigenetic changes in oral cancer is concerned. And this deals with heritable alterations in gene expression, unrelated to change in DNA sequences or DNA mutations. This could include things like DNA methylation, histone modification, ATP-dependent chromatin remodeling, and the so-called non-coding RNA-mediated gene silencing, which is receiving a lot of attention. This is once again the same reference from previously from oral and maxillofacial pathology, and this is a summary of the molecular markers. Another term for potentially malignant disorders, the PPOEs. I want to draw your attention to the fact that what you see within the box are all epigenetic changes, which include DNA adduct formation or methylation, histone modifications, and microRNAs. And this list is growing every day as more and more investigators are working on this field. So it is important to keep in mind that not only the DNA alterations like LOH and ploidy are important, but epigenetic events may also be significant in different aspects of our and studying and managing the potentially malignant disorders. Okay, now coming back to the clinical problem. So all potentially malignant disorders do not become cancer. Yes, we could use dysplasia. Yes, we could use LOH or loss of heterozygosity and ploidy analysis. Yes, we can probably analyze epigenetic changes, but this is a complex mixture of problems, one. Two, and all of us may not have access to all these facilities, especially in developing countries. So are there any other factor which can help us predict malignant transformation from the clinical setting and from a resource-constrained setting? Yes, there are certain factors. This is a busy slide. Please follow me. I'll take you through the slide. You have clinical features and histological features here. We have those which are a strong indicator of malignant transformation of OPMD, a weak indicator, and that which lies in between. Strong indicators of malignant transformation as far as clinical features are concerned is that when the lesion is greater than 200 square millimeter, larger the lesion, the higher the chance of malignant transformation. If it is non-homogeneous, I showed you examples of that, either thick verrucous, if it is a speckled or a erythroleukoplakia. In fact, if you have an erythroleukoplakia, what we consider at a center is all erythroplakias are malignant unless you can prove them otherwise with biopsy, because erythroplakias carry a higher risk of malignant transformation. Certain sites, especially the lateral surface of the tongue and floor of the mouth, there is a predilection for early malignant transformation. So these are the clinical features which carry a high connotation as far as malignant transformation is concerned. A larger size, a non-homogeneous appearance, an erythroplakia or a speckled leukoplakia, and if it occurs in the tongue and floor of the mouth. A medium risk predictor is in the female gender, and if the patient is greater than 50 years. Ironically, in non-smokers, it's got a higher risk of malignant transformation. The reason is, if there is a history of tobacco use, the tobacco is responsible for mutagenic changes, and that probably drives the cell to cancer. Whereas in the case of a non-smoker, there is no obvious risk factor. So probably the patient has an inherent disposition for spontaneous mutation or other factors which is pushing the cell towards a malignant transformation. So that's probably the reason why non-smokers have a higher incidence of malignant transformation of the potentially malignant disorders. And this is a no-brainer as far as histology is concerned. In the three-tier system, if the dysplasia is severe, it's got a higher risk of malignant transformation. Or if you're using a two-tier system, if it is a low grade or if it's a high grade or a high risk lesion, then it carries a higher risk of malignant transformation. Now, this is interesting. Hpv positivity is intimately associated with prognosis, not so much so in oral cancer, but in oropharyngeal cancer. It's very important. And like I said in the last few slides, ploidy analysis and loss of heterozygosity of multiple genes could also be a good predictor of malignant transformation in potentially malignant disorders. Okay, let's quickly talk about HPV, and we need to get this out of the way. The first thing I need to tell you very clearly is that oral cancers by and large are not associated with human papillomavirus. And if you remember the first few slides, I said head and neck cancer are heterogeneous. You have oral cancer, you have oropharyngeal cancer, and you have cancer of the lip. It is the oropharyngeal cancer which has got a high association with human papillomavirus. This is a nice article, a recent article for reference by Lewis et al. In the Archives of Pathology Lab Medicine. It sums up a lot of the studies. They sum up about 2,200 peer-reviewed articles, and they have about 14 recommendations. I'm not going to go through all the 14 recommendations, but a few which may be clinically relevant. The first is high-risk HPV, that is for HPV 16 and 18, testing is mandatory on all newly diagnosed oropharyngeal carcinoma. So if a patient presents with oropharyngeal carcinoma, it's imperative that you do a HPV testing. A high-risk HPV testing is not necessary for non-squamous carcinomas of oropharynx or non-pharyngeal carcinomas of the head and neck. So in these situations, you do not have to do a high-risk HPV testing. And this is an interesting conclusion of the 14. P16 overexpression is strongly associated with transcriptionally active high-risk HPV. So you can use P16 immunohistochemistry as a surrogate marker for HPV infection in oropharyngeal cancer. So instead of looking for in situ hybridization of HR-HPV, you could do a P16 as a surrogate marker in oropharyngeal cancer. And for HPV, high-risk HPV positive or P16 positive cases, the tumor grade or differentiation is not necessary for planning a treatment. So once they are HPV positive, especially the high risk and the P16 type, they usually have a better prognosis, and usually you have a standard set of operating procedures in different institutions. So you need not necessarily fall back on whether they are low grade, moderately differentiated, high grade or not. So you do not necessarily have to do the differentiation status or the tumor grade in these patients. These are the 4 important take-home messages as far as HPV is concerned. Quickly, something I grabbed in the news recently. In fact, you have a non-valent vaccine for oropharyngeal head and neck cancers caused by HPV, and that's been FDA approved. So HPV is important in oropharyngeal cancers. All this is fine. We looked at the different types of leukoplakia clinically. We looked at the risks of malignant transformation. We saw the 3-tier and the binary system of classification. We saw how molecular analysis could help you overcome the dilemma of which is going to malignantly transform and which is less likely to. We touched upon the significance of HPV infection, but how do you put all these together to manage these patients clinically? Now, this is a nice clinical flow chart published in JADA. It's a busy slide. Let me just take you to the highlights. This is the clinical pathway for evaluation of potentially malignant disorders of the oral cavity. You have 3 groups. One, where there is no clinically evident lesion or symptom. Then you have a group where a clinically evident but seemingly innocuous lesion. What exactly do you do? And then you have a clinically evident suspicious lesion. Either it's a potentially malignant disorder or a malignant disorder. My point to highlight is this. If you have a clinically evident lesion, which falls under the PMD subgroup, you need to perform a biopsy or at least refer them to a specialist. This once again because what seems like a leukoplakia, which is the most common type of potentially malignant disorder, when you take a biopsy, it can come back as node dysplasia, the different grades of dysplasia, or a squamous cell carcinoma, and this cannot be overemphasized. And this is a very interesting slide by Professor Spite and his group from the triple O, some 4 rows, of course. It puts together all that we have discussed so far, the history of the lesion, what exactly should you look for during examination, and what you look for in the biopsy. What are the signs of suspicious oral lesion? And we discussed that there's a difference between the male and female, age greater than 50, a non-smoker, a persistent smoker, and sites like tongue or floor of the mouth. And if it is erythroplakia, you straight away go to biopsy, and that was the point I was trying to make. You don't look for anything else. If it's a leukoplakia, you look at the different types, homogeneous or the different types. If it is verrucous or speckled or proliferative verrucous leukoplakia, then you definitely need to biopsy. If it is very mild and homogeneous, associated with a habit, many a times we ask the patient to discontinue the habit, wait and watch periodically. And if there is any transformation, then we go ahead and do the biopsy. So this algorithm puts together the features which you get in the history and the type of lesion when you examine them clinically. And once you biopsy them, how you would stratify them as mild, moderate, or severe, and then low risk or high risk, depending upon the clinical features, or if you have access, depending upon the molecular lesions associated with the potentially malignant disorder. The idea of all this is very, very simple. Instead of treating all patients with surgery and radiation, you're moving towards the era of individualized therapy. For very many tumors, you have therapy which is tailored for that particular patient, for that particular tumor. And you have what's called healthy to cancer to survival. And there are many factors involved. You have chemoprevention, which is taking a big step. And this is what I'm talking about. You have risk stratification in clinical trials. You have what's called personalized therapy and personalized follow-up. These take into account not only the clinical features, not only the histological features, but also the molecular features of the lesion and the genetic makeup and the epigenetic makeup of the tumors. So when you combine all these together and then you work with different teams in the oncology department, the clinical, the pathological, and the oncosurgeon, or the radiotherapist or the chemotherapist who's handling the case, then you can stratify each of these patients into a particular group to provide optimum, personalized, specific therapy for that particular head and neck cancer for that particular patient. Let me stop here and thank you all for your undivided attention. Over to the administrators. I need to stop this screen sharing in just a minute here.
Dr. Simaprit Sandhu, would you please ask the questions from the Professor Ranganathan? We have received some questions in the chat box. If you could kindly ask the questions.
Yeah, I have an access. No, I have an access. Thank you so much. I think there is some voice. Am I clear?
You are clear, Simaprit, yeah.
Okay. And thank you, Dr. Ranganathan, for such a beautiful insight into what is a very, very tricky lesion. And there are loads of questions, there are loads of compliments for the wonderful presentation. Thank you for enlightening us. Now, the first question, if with your permission, do I start the question and answer round, sir? Do we start the interaction, sir?
Yeah.
Dr. Ranganathan, yeah.
Yeah, please.
So, yeah, the first question is from Dr. Firsten Kelsey, who's from Indonesia. And she would like to know that, according to you, which is better, the 3-tier or the 2-tier system?
Hi, Firsten, nice to hear from you. That's a loaded question, if I may say so. We currently use the WHO 3-tier system. It looks like the 2-tier system works a little bit better. And what we are trying to do is, and that was why we did the particular study in a multi-center, we are trying to validate. And what I would strongly encourage is if different people in different centers have the patient's longitudinal records and you compare the binary and the 2-tier system, maybe by the time WHO comes for the next round of classification, the 2-tier system would become established. And in fact, WHO on their 3-tier system, there's a comment which says that the 2-tier system should be validated so we can move towards the low risk and the high risk lesion. So to answer your question, the 2-tier looks to be better, but currently we use the 3-tier system. And the reason is it needs to be validated. It hasn't been around as long as the 3-tier system. So we're still comfortable using it.
Thank you so much. And I hope, Dr. Kelsey, your question gets answered. Now we have another question from Dr. Mohammed Dahavi. And he's asked, that the combination of dysplasia and lichen planus resulted in so-called lichenoid dysplasia. Now, it was not accepted in medical medium. What is your view about diagnosis of lichenoid dysplasia? Should the term be used or should we just use the term dysplasia?
Yeah, that's a very good question. You know, that's why the slide in which I showed you the oral potentially the different types of leukoplakia, I made an allusion to the fact that it's a clinical diagnosis and dysplasia is a histological diagnosis. Okay, now this came about because you had lesions which look clinically like lichen planus, but when you, excuse me, when you biopsy them, it becomes dysplasia. So they should be treated as dysplasia. If you're calling it lichenoid dysplasia, just dysplasia, probably we are splitting hairs, but they should be treated as dysplasia. And the reason why lichenoid dysplasia falls out of favor is because it actually doesn't tell the clinician what to do, whether to treat it like lichen planus or dysplasia. And this is once again the reason why, at least what we do at our center, we work with the clinicians and the surgeons very closely and look at the lesion. And if it is clinically predominantly lichen planus, and I did make a mention that sometimes dysplasia can be tricky when there is a lot of inflammation. So in lichen planus, there tends to be a lot of inflammation. And so you may misdiagnose dysplasia. So to cut a long story short, what we do is if you see a lichen planus clinically and evidence of dysplasia, we do a few treatments. In a lot of our patients, we have Candida infection. We treat for Candida. A lot of times a lichen planus lesion sort of resolves by itself. Then we come back and if clinically the lesion has resolved, we just follow up the patient. But even after the therapy, if the lichen planus still persists, and if it is dysplasia, we treat the patient like a potentially malignant disorder and move on.
Host has muted me. Yeah. So there is another question by Dr. Dipanshu Agarwal. And he wants to know that he just has one marker facility, that is P53 in his department. And he wants to know, how do we harness potential of P53 marker in diagnosis along with histopathology in cases of dilemma? So how can he make maximum use of P53?
Yeah. Yeah, that's a good question. You know, the fundamental caveat in immunohistochemistry is never use one single marker. I do realize the limitations we are working under here, but using a single marker is very, very difficult. I mean, we have a sort of statement we make when we do immunohistochemistry. There is no single marker which can tell you differentiate between a benign and a malignant lesion. Of course, you can look at proliferation markers and things like that, but it's not a single marker. So P53 is a good marker, but by itself, it has got a very limited potential in prognostication. So you may have to club it with other markers. It's at this point in time, that is the scenario.
So one very common question, and we've tried to, write it from everybody, is what is the difference between erythroplakia and rhythmatous candidosis? So a lot of people ask this question. So just wanted to take your views, and that's the last question. Yeah.
Yeah, this is a little bit difficult because, and it's a good question too, because both of them look red in color. Because erythroplakia can be red, and rhythmatous candidiasis is also red in color. And erythroplakia is cancer unless otherwise proven, and erythematous candidiasis can be treated quickly. One point is the location. Usually the erythematous candidiasis is in the palate and on the dorsal surface of the tongue, or on both the sides, what we call the kissing lesion, though it can occur in other parts of the body. 2, the history. It's usually of a shorter duration. 3, it is usually associated with burning sensation, candidiasis, but sometimes erythroplakia can also be associated with the burning sensation. Then you could do what is called, when we talk about candidiasis, we talk about 2 things. We call a presumptive diagnosis and a definitive diagnosis. You could always do a smear and look for candida, but very many a times from the palate particularly, even if you do a smear, you may not get candida in the culture. So what you could do is you could treat the patient for candidiasis, which is a non-expensive, safe, relatively safe, quick treatment. So within a week, if it is erythematous candidiasis, it will resolve. And erythroplakia will not resolve. That's the 4th point. And final point is, of course, look for features in the patient which could predispose them to candidiasis. So you need to club all these together to differentiate between erythroplakia and erythematous candidiasis. And that's a very good question because it's a clinical dilemma which you may face, though not often. It can be tricky to handle.
Thank you so much. And with regret, I would like to close the question and answer interaction round here because we're running out of time. We have one more speaker, and all the other questions will be, we'll pick up the questions and we'll mail them to Dr. Ranganathan, and he shall get back to you. And thank you so much. Now, may I request Dr. Mahadavi, who's the head of the Department of Oral and Maxillofacial Pathology at Tehran University of Medical Sciences, to facilitate our speaker, Dr. Ranganathan, with the E-certificate. Over to Dr. Mahadavi.
Thank you very much, Dr. Sandhu and Dr. Ranganathan, for your great presentation. It gives me a great pleasure to be here today and listen to your informative lecture. Thank you very much, Dr. Sandhu and Dr. Ranganathan, for your great Ranganathan. I'm honored. It gives me a great pleasure to certificate and listen on behalf of the lecture. Thank you very much, Dr.
Thank you. Thank you.
Sandhu and Dr. Ranganathan, for your great Ranganathan. I'm honored. It gives me a great pleasure to certificate and listen on behalf of the lecture. Thank you very much, Dr.
Thank you. Thank you.
Sandhu and Dr. Ranganathan, for your great Ranganathan. I'm honored. It gives me a great pleasure to certificate and listen on behalf of the lecture. Thank you very much, Dr.
Thank you. Thank you.
Sandhu and Dr. Ranganathan, for your great Ranganathan. I'm honored. It gives me a great pleasure to certificate and listen on behalf of the lecture. Thank you very much, Professor Ranganathan and Professor Sandhu. So now I would like to invite Professor Dr. Amini Shakib, Associate Professor in Oral and Maxillofacial Pathology in Tehran University of Medical Sciences and Vice Dean for International Affairs of School of Dentistry, TUMS, to give his lecture with the topic of oral squamous cell carcinoma from diagnosis to the reporting. Please welcome, Doctor.
Okay, hello everyone. You have my voice?
Yes, yes.
Okay, let me share my screen. Okay, hello everyone. First of all, I would like to express my appreciation for arranging such
آقا من شروع میکنم نویسی میگم یعنی سکوت محض نباشه تا شما بیاین بالا. Okay. Okay, do you have my voice?
Yeah, Dr. Point, you're fine.
Yeah, you are loud and clear, Dr. Puan.
You have Dr. Simarpreet, do you have my voice?
Yes, you are loud and clear. We can hear you. Please carry on.
Okay, sorry. I do apologize for the technical problem. I would like to thank the organizer of this webinar, Asian Society of Oral and Maxillofacial Pathology and Tehran University of Medical Sciences. And also I would like to express my appreciation to Professor Ranganathan for his brilliant presentation, and also Dr. Simarpreet for supporting this webinar. Also, I would like to thank Dr. Mandana for providing such connection between Tehran University of Medical Sciences and also Asian Society of Oral and Maxillofacial Pathology. And also I would like to thank Dr. Mahdavi, head of the department, for her nice introduction. Next, please. Okay, I will have a presentation on oral squamous cell carcinoma, how we can make a precise diagnosis and how I can provide a well-descriptive report on oral squamous cell carcinoma. At the beginning, I would like to explain that I am a member of Oral and Maxillofacial Pathology Lab at the School of Dentistry. We have about 1,000 specimens a year. Usually we have incisional biopsy in our center, but also I have a member of Cancer Institute. It is a great pleasure for me to be a part of a Cancer Institute hospital laboratory with a great number of specimens, especially resected oral squamous cell carcinoma. In this presentation, I will have a short introduction about oral squamous cell carcinoma, and after that we have a look at the protocol of reporting cancers of the lip and oral cavity by College of American Pathologists. And after that, we will have a look at 8th edition of a staging manual, T category, especially focusing on depth of invasion, which is recently introduced in this protocol. Also, we will have a look at histologic risk model in oral squamous cell carcinoma, and we will have a look at most promising biomarkers in oral squamous cell carcinoma, and we will have a conclusion. Okay. As you know, oral squamous cell carcinoma is the most common cancer in oral cavity. About 94% of all oral malignancies are oral squamous cell carcinoma. It is between 8th and 11th most common cancer worldwide. And the risk of intraoral cancer increases with increasing age, especially in males. About etiologic factor, you know that oral squamous cell carcinoma is a multifactorial cancer. Several intrinsic and extrinsic etiologic factors have been proposed for this cancer, for example, tobacco smoke and alcohol consumption, and also iron deficiency anemia as an intrinsic etiologic factor. About clinical presentation, Professor Ranganathan well described the clinical features of pre-malignant lesion, and he well mentioned about oral squamous cell carcinoma. And in a brief review, we may have an exophytic lesions when we face oral squamous cell carcinoma. Also, we may have ulcers with endophytic appearance, and after that, we may have Leukoplakia-like features and appearance in oral squamous cell carcinoma. You can see here a leukoplakic appearance of oral squamous cell carcinoma, and at the end we may have Erythroplakia. Professor Ranganathan well explained that we may have a combination of Erythroplakia and Leukoplakia, which may be, speckled leukoplakia or erythroleukoplakia. Let's have a look at this case. Case 1, we have a lesion on lateral border of tongue of a patient. You can see photomicrograph in this slide. At the right side, we can see normal epithelium, and the left side, you can see pathologic changes, including oral squamous cell carcinoma, nest of epithelial cells invading subjacent connective tissue. And if we have more magnification, we have a look at the subjacent connective tissue with more magnification, You can see here nests of epithelial cells invading adjacent connective tissue with prominent keratin pearl formation. And with the higher magnification, you can see small nests invading in the depth of the striated muscular bundles, and it is an ominous sign for such cancer. It should be well evaluated by the pathologist during providing the dissection of the specimen, providing providing the specimen microscopic slide. And you can see even at the bottom of the, you can see there a small nest with even 2 or 3, epithelial cells arranging together. Next. Yes, as the first take-home message, it is important to know how should a pathologist write a diagnosis in an incisional biopsy. It seems you should mention all necessary information even in your incisional biopsy, because it is important for the clinician, for the surgeons to plan for the next treatment approach. It is highly recommended to mention histologic grade of the oral squamous cell carcinoma. It is recommended to measure depth of invasion of the tumor, and if it is possible, provide a full thickness of the tumor to the deeply located normal tissue to report depth of invasion of the tumor. Also, it is recommended to meticulously evaluate the microscopic slide to find if there is a lymphovascular invasion or perineural invasion. And as the second take-home message, it seems very important to provide a precise incisional biopsy for the pathologist. It's very important, and the clinicians should be aware about providing a full thickness with sufficient depth for the pathologist. Okay, let's have a look at the protocol for reporting cancer of the lip and oral cavity, published by College of American Pathologists. At the first part, it is important to mention a procedure, performed by the surgeons, and also tumor size and tumor laterality and tumor focality. And at the second part of your report, it is very important to mention histologic type and also the size. As you can see in this protocol, you're supposed to mention tumor depth of invasion, and also it is recommended to identify the histologic type of the oral squamous cell carcinoma. And at the third step, it is recommended to mention the histologic grade and also tumor extension. It is very important for the clinicians to be aware about the surrounding normal tissue, if are invaded by the tumoral nest or not. For example, if alveolar bone is invaded, if salivary gland tissue around the tumor is invaded, or other normal structure surrounding oral squamous cell carcinoma. And the other part is this margin, surgical margin. It is very important to be meticulously evaluated and reported in your path report. Some clinicians, some surgeons submit surgical margins in separate containers to the path lab, even operative for frozen section evaluation, but some surgeons submit their specimen as a whole resection. And the pathologist should be aware about how to provide surgical margins and how to report it to the surgeon. It is highly recommended to be in close connection, to be in touch with your surgeon, and try to be aware about how he commonly plans for the surgery. Yes, and as I mentioned previously, lymphovascular invasion, perineural invasion should be mentioned in the path report. Worst pattern invasion, I will talk about it. The previous one. Please. Worst pattern of invasion? No, previous one. One more. Okay, and it is very important to have to report worst pattern of invasion. Worst pattern of invasion. Worst pattern of invasion. It is optional in protocol published by College of American Pathologists. Next slide. And next one. Okay, let me explain two important issues in your path report. Previous one. Let me explain two important issues in your path report. The first one is about final margin. As I explained, it's very important to be in touch with your surgeon, because sometimes you may use obscure term. For example, when you report the surgical margin is close to tumoralness, it's very important to well describe the meaning of the close. Do you mean 5 millimeter, 7 millimeter, or less, or than these measurements? Therefore, it is highly recommended to be in close connection with your clinician. And as a second issue is about epithelial dysplasia. As Professor Ranganathan well described, we have a 3-tier grading system for epithelial dysplasia, mild, moderate, and severe dysplasia. According to CAP protocol, mild epithelial dysplasia is considered as free margin. And also severe epithelial dysplasia is considered as involved margin, but CAP recommend to consider moderate epithelial dysplasia as involved margin, as a positive margin. But I'm not brave enough to report moderate epithelial dysplasia as positive margin, but it is a recommendation from CAP. And I should emphasize again that it's very important to to convince your surgeon about your report and how to write your report. The other issue is about subjacent alveolar bone. Sometimes tumoral nest invade cortical bone of the adjacent alveolar bone. It is recommended to consider it as it is recommended that not to mention involvement of the cortical bone in your path report, because involvement of the bone is essentially based on involvement of medullary cavity of the alveolar bone. And it is very crucial for the pathologist to differentiate medullary involvement of the alveolar jawbones or cortical invasion. Therefore, please report medullary involvement if you see in your path report, if in the microscopic slide, please report it in your path report. In the section of extension to, extension to surrounding normal tissue. And we have recently published 8th edition of AJCC, American Joint Committee on Cancer. We have a change in T category, pathologic tumor size, and it is depth of invasion is proposed as an important criteria. Next slide, please. You know, in the former edition of staging, we have a term as tumor thickness. It commonly measured from the mucosal surface of the epithelium to the deepest point of the tumoral invasion. But in the recently published protocol, it is recommended to draw a line from the basement membrane of adjacent normal tissue, and after that provide a plumb line from the horizontal line to the deepest point of the tumoral invasion, and it is called at depth of invasion. In this slide, you can see a comparison between tumor thickness and depth of invasion. Sometimes it is shorter, depth of invasion is less than tumor thickness, and sometimes it is more than the other one. But it is recommended to use depth of invasion instead of tumor thickness in your path report. Next slide. Next one. No. Yes. And as I mentioned, that it seems that depth of invasion might be a better predictive parameter than tumor thickness. And according to AJCC protocol, after when you every 5 millimeter increase in depth of invasion, pathologic tumor size category will increase 1 level according to the following. When you have less than 5 millimeter depth of invasion, you have a pathologic T1. And when you have more than 5 millimeter, but less than 10 millimeter, you have pathologic tumor size 2. And more than 10 millimeter is considered as pathologic tumor size 3. Next one. And you can see here when you would like to report the staging of the oral squamous cell carcinoma, you should consider a combination of tumor size and also depth of invasion. And it seems that it would be a well representative of the prognosis of the oral squamous cell carcinoma. And the histologic risk model is proposed as a useful tool to assess risk of recurrence and death of the patient suffering from oral squamous cell carcinoma. It was proposed, I think, about 15 to 20 years ago by Professor Brandwein, and it is a combination. It is a combination of perineural invasion, lymphocyte host response, and worst pattern of invasion. College of American Pathologists has recently added WPOI, worst pattern of invasion, as an optional criterion in recently published protocol. As you can see in this table, type 1 is considered as a pushing border, type 2 as a finger-like growth, and large separate islands, more than 15 cells per island, is considered as a type 3, and small islands considered as type 4, and type 5 is representative of a small satellite located away from the main tumor at least 1 millimeter in measurements. And therefore, it is recommended to use this part of histologic risk assessment model in your report, although it is optional. In the case 2, we had a 73-year-old female with a lingual lesion. Let's have a look at the photomicrograph of this patient. No, I cannot see. I think I have a delay. Sorry, I think I cannot see the next slide yet. Okay, I can see now. I can see now. But you can see here photomicrograph. I can see photomicrograph of the hematoxylin eosin stain specimen. You can see here at the right side normal epithelium with prominent hyperkeratosis and mild to moderate epithelial dysplasia. And at the left side, you can see a tumoral nest invading adjacent connective tissue. With higher magnification, you can see tumoral nests with significant cellular atypia. You can see here tumoral giant cells. You can see atypical mitotic figures in this slide, and also prominent nuclear polymorphism and cells with prominent nucleoli. It seems that we cope with a tumoral high-grade oral squamous cell carcinoma. Also, you can see here mitotic figure, several mitotic figures in higher magnification in, and also atypical mitotic figures. I would like to pay attention, to invite you to pay attention at the grade of the tumor. You can see here as take-home message 3, although histology grade of the tumor does not have a direct role in staging of the tumor, but it seems that histology grading might be a well descriptive of prognosis of the oral squamous cell carcinoma. Therefore, I would like to invite you to evaluate each microscopic slides meticulously. You can see here Ali Farid Safi and his colleagues proposed a novel histopathologic scoring system for patients. It showed that the importance of reporting histology grade in your path reports, and unfortunately sometimes we ignore reporting this important criterion. And at the end of my presentation, I would like to invite you to have a look at promising biomarkers for early diagnosis and prognosis prediction of oral squamous cell carcinoma. There are several, many biomarkers have been proposed in literature to predict prognosis of the squamous cell carcinoma. But as I think Professor Ranganathan explained in his informative lecture, none of them are not, at least in oral squamous cell carcinoma, are not well descriptive and well prognostic, investigation, and several investigators and also researchers are working on these prognostic factors to provide a well descriptive prognostic biomarkers. Next one. Okay, and I cannot, none of them are not reliable. As conclusion, it seems that it's very important to provide meticulous sections for microscopic evaluation of the specimen, and it is recommended to spend enough time to review hematoxylin and eosin stained microscopic slides. And I would like to invite you to follow CAP protocol in your lab, and also be in close connection with your surgeons in your center. And at the end of this presentation, I would like to dedicate this presentation to a legend of oral and maxillofacial pathology in Iran, the founder of the oral and maxillofacial pathology in Iran, Professor Dr. Ismail Yazdi. Unfortunately, he passed away about 6 months ago because of COVID-19. And he was founder of this field in Iran, and I would like to wish rest in peace. Okay, thank you very much for being with me in this presentation. I would like to express my apology for a technical problem, and I hope to be in touch with you via email and Instagram and Twitter. Thank you very much.
Thank you very much, Dr. Shakib, for the informative and practical presentation, like always. So now I'm gonna ask some questions received from the audiences. But of course, we've received lots of questions, but I'm gonna focus on the most common ones. So the first question is, which type of biopsy you recommend, sir? Punch biopsy or incisional biopsy?
It's very important questions. It is, I think it is a clinician's problem at first, but for the pathologist, the depth of biopsy is very important, because pathologists are supposed to evaluate the depth of invasion, and pathologists need to have enough depth of the tumor and also adjacent and subjacent normal tissue to evaluate depth of invasion. I can recommend you to, as a pathologist, the proper type of a specimen for me to have a good report, path report, is incisional biopsy, and then I would rather have an incisional biopsy instead of punch biopsy.
The next question is, in India, most cases of oral squamous cell carcinoma are habit-related, tobacco or areca nut. How do you find it? The most leading cause of oral cancer is in Iran.
You know, I don't have enough information about epidemiologic, you know, survey on this issue. But unfortunately, as you know, when you know the etiologic factor of the tumor, it might have a better prognosis. But unfortunately, we face several oral squamous cell carcinoma patients, especially in our center, in Cancer Institute Hospital, with unknown cause. It is very ominous sign of we don't have a clear plan for the future, and we don't have a well descriptive information and epidemiologic study on this. But in this case, in case of your question, unfortunately, I don't have enough information about epidemiologic, you know, information.
Thank you very much. The last question I'm gonna ask you, of course, there's more questions, but the last questions whom we have time to ask is it necessary to induce margins and inflammation status in incisional biopsies?
Good question. As I explained for you, according to histologic risk assessment, lymphocyte host response should be reported in path report, but there is no agreement, general agreement on reporting you know, lymphocyte host response in all the specimen. As you can see in the CAP protocol, the pathologists are not supposed to report it, but some centers, some expert pathologists recommend that that report the histologic risk, you know, report lymphocyte host response in your incisional or excisional resection biopsies.
Thank you very much, Dr. Shakib, for your nice and informative presentation. Now I'm honored to present the certificate to you, and thank you very much again for your informative presentation.
Thank you very much for the certificate, and it was a great honor for me to be with you all, especially Professor Dr. Ranganathan, Dr. Simarpreet, Dr. Mandana, and also my talented and my enthusiastic colleague, head of the department, Dr. Mahtabi. Thank you very much.
Thank you. In the end, from my side and on behalf of our department, I'd like to express my gratitude to the eminent professors, Dr. Ranganathan, Dr. Sindhu, and especially Dr. Mandana for this webinar. And also thank the audiences for their time and attendance. Thank you very much. Thank you, Dr. Shakib.
So I think it's time to call it a day. Have a good day, guys.
Thank you. Bye. Have a nice day.
Bye. Have a nice day to all of you.
I can.
Yes.
Okay. Sorry.
Thank you, everyone.